provide education on utilizing the antimicrobial resistant laboratory network for screening. Just a moment. Okay. Okay, so what have we seen in Nevada? So our first clinical case was collected on August 21st, 2021. As of June 23rd, we were seeing a total of 300 cases. 122 of those have been clinical. 178 have been colonization cases, where we've identified a clinical case and then had screening done on units where those cases were identified. Out of those 300 cases, 5 of them have been pediatric, which is extremely rare. CDC will mention some of the unique items that we've seen here in Nevada, which one of those are having pediatric cases. So some of those unique factors are surges in acute care hospitals, which normally you'll see a surge in long-term acute care and skilled nursing, especially those with a ventilator unit. Usually there'll be more colonized cases than clinical, and I'll show the graph of what our cases look like, clinical versus colonization initially. Now you see that we are having more colonized cases versus clinical cases, and then the pediatric cases, as I mentioned. So when we started the EPI-aid, which was requested in May of 2022, we had 64% clinical cases and 36% screening cases. When you look at that compared to what other states saw, the majority of their cases were screening cases versus clinical. So just an overview of our cases. Currently, there are a total of 22 facilities that are involved. 10 of those are acute care hospitals. And because our regulatory authority does not break out long-term acute versus acute care, those 10 do include acute care, long-term acute care hospitals. 8 are skilled nursing facilities. We broke it out, I'm sorry. So 10 are acute care, 8 are skilled nursing, and 4 are long-term acute care. But sometimes when you see our numbers, it'll just say a total number for hospitals. That would be your acute care and long-term acute care included. There are a total of 5 clades. For Auris, we've recognized 3 of them here. Majority of our cases have been clade 1 and clade 3. So those are identified based on where they were first located, identified in the nation, well, in the world. The clade 1 is identified in South Asia, and clade 3 is African. We have not seen clade 2, which is East Asian. We did have 1 clade 4 case that was identified in South America, but that one did not see transmission, thankfully. And clade 5 is Iranian, which is not yet found in the US. So some challenges that we encountered was just the understanding that Auris was a multi-drug resistant organism, and it wasn't just your routine Candida infection. So there were times when we were notified that when staff saw that it was Candida, patients were taken off of contact precautions instead of being kept on. So that introduced a gap there in their infection prevention. A lack of communication between facilities. Some facilities received cases where they did not know the patient had Candida auris until we notified them. When that occurs, based on CDC guidance, we have to implement screening of the entire unit, of course, of roommates, to make sure that there was no transmission. And oftentimes we found that transmission did occur on those units. Compliance and reporting. People were not aware that this is a federal reported organism. So there was, they didn't perceive it as mandatory, so we didn't get timely reporting at times. Utilizing ARLN, which is why we have Emily on. There's been issues with specimen collection, proper labeling of the specimen and mailing of specimen. When they don't receive all of the information based on the instructions they provide, that slows down their process of testing and providing results. And then also we had to create an internal system to track Candida auris, since this was a new organism that we hadn't seen. And then gaining our education on CRS and prevention practices. So just some details on our CDC EPI-AIDS visit. The visits were conducted May 16th through May 27th. We visited 6 acute care hospitals, 2 long-term acute care hospitals, and 1 BSNF. Within those visits, we did tours of the facility. There was data extraction based on cases that were previously identified at these facilities. Utilizing the ICAR tool from CDC of infection control assessment was conducted, and that also included interviews with their infection prevention staff and environmental service staff. And then environmental sampling also took place at 3 of the acute care hospitals, as well as observation on their environmental service practices and infection prevention practices. With the observations, we were looking at compliance in hand hygiene, compliance and proper PPE use, as well as effective and appropriate cleaning and disinfection of high-touch surfaces and patient rooms. So this just kind of describes what I just went over of what we looked at, and also like their transmission-based precautions. So gaps that we identified utilizing the environmental swabs. The swabs were used to take samples on patient surfaces in their rooms, doorknobs, sinks, splash areas where medical equipment was stored that could be possibly contaminated, medical equipment, rehab equipment, just various surfaces throughout the facilities. We did find growth of CRs in patient rooms on rehab equipment and door handles. Pseudomonas aeruginosa was found in a bathroom sink. Oxa 28, Acinetobacter baumannii was found on a door handle, and Enterobacter cloacae and Enterococcus faecium in an RN sink. And these are of concern because they, of course, are contamination sources. If the surfaces aren't properly cleaned, that's a mode of transmission to other patients. But also you'll find that these patients can be co-infected with carbapenem producing or carbapenem resistant organisms. So the sinks were a concern because that can be a growth area. So that's why those sinks were tested, and in which you found that Pseudomonas was grown there. So making sure medical equipment and things are not stored where they can have a splash from water is also a mode of prevention of the carbapenem producing and carbapenem resistant organisms. We do have a meeting set up with CDC tomorrow because guidance will be going forward to have any patients that are coming from Southern Nevada facilities screened, and also additional screening of which carbapenem producing and resistant organisms we should also co-screen for to make sure that they're not infected with those as well. We also identified missed opportunities for hand hygiene, for correct PPE use when donning and doffing before entering and exiting rooms with patients who are on contact precautions, and infection prevention practices during wound care. Efforts, just some of our efforts to date from the HAI program. Initially, we released a technical bulletin in April of 2022 to bring awareness to all the medical facilities in Nevada of the increasing cases that we were seeing. We work with educating facilities, providing access to screening supplies. Our ACQC team has awesome infection preventionists that go on site to help identify the gaps in infection prevention and to provide a census on site, data collection and analysis. We have implemented mandatory screening in high-risk settings identified by CDC, which are the long-term acute care hospitals and VSNFs, or SNFs with skilled nursing facilities with ventilators. So they screen the ventilator unit, and if we identify a high number of cases, then for the SNFs, that screening will be extended to other areas of the facility or the whole facility, whereas long-term acute care facilities would do screening of all of their patients to identify any colonized Candida patients. Working with the results that we have received, development of a high priority list for our IPs to go out and do their infection control risk assessments. We continue to collaborate and receive guidance from CDC. One of our ACQC infection preventionists developed a CRS toolkit, which guidance from CDC has been updated. So we'll work to get that updated version posted to our HAI website. We've also updated the inter-facility transfer form to include CRs and we continue to communicate and collaborate with our stakeholders in the healthcare facilities and our local health authorities. Some helpful resources. We will provide the slides for this training, so I will provide the actual link for these. But CDC has a great Candida Auris page with a lot of information for patients, for healthcare providers, physicians, your laboratory staff or pharmacists. We have a YouTube video of a COCA call from CDC. The List P products from the EPA are the products that should be used to clean and disinfect your surfaces. If you cannot access those items, List K can also be used. As I mentioned, our CRs toolkit, which is posted on our HAI website, and our interfacility transfer form. And that form, well, let me go over the lab form. So if you are sending specimen to our state lab, please make sure you complete all of the items in the box, especially the ordering facility name. If you do not put your facility name, then we do not know where that patient is located, and it's very hard for us to try to trace back where that patient is located in order to conduct our investigation. And this is a form that we created as a state some time ago, and it just gives an overview of the patient and what type of infections they have. At the bottom, there is a part that says like labs are pending and who to contact in order to get the results for the labs. If you are pending results for CRs, please make that known. To say that the information and the micro reports within their labs and different items, we all know it's very hard to search through those to find all of that information. So if you can use your own form within your own electronic databases, or if you want to adopt this form and use it for intake purposes to collect all that information so that you know how to properly place these patients within your facility, if they need to be isolated, if you have other patients that can be cohorted with that have the same organisms that they have. This information needs to be shared before that patient is discharged from your facility and received at another, because that is it's a gap that we've identified, that people are unaware that they're receiving these patients. And then now we're having to kind of work backwards to see if anybody was infected, if there's transmission, if they were put on contact precautions because of other organisms that they had. To know what you're dealing with as a facility up front is very helpful. So we really need to work on our communication between facilities. This is my contact information as well as CT's contact information. If you have any questions, you can email us directly. This email, dpbhhai, I spelled health wrong, I apologize for that. It's supposed to be at health.mv.gov. That goes to the entire HAI team. So in the event that one of us are out, you can email this email address here, and I'll put the correct spelling of that in the chat. That goes to everybody on the team, so anybody can answer that and reach out to you and answer your questions or any concerns that you have. And I will turn it over to CDC for their presentation. Thank you very much.
Thanks, Kanisha. And I am going to work on pulling up my slides. Can you all see them?
Yes,
I can see them.
All right, excellent. Well, thanks for having me join. I had the privilege of being out in Southern Nevada. So might have even met some of you, but got to work closely with the health department. And I'll be doing this presentation, but Katie Forsberg, we work very closely together, and she's also on the line and available to also answer questions. All right, so we'll get started. So I'm sure many of you have heard about MDROs, multi-drug resistant organisms. I feel like we use that acronym all the time, but just to make sure we're on the same page, these are pathogens that are resistant to all or most antimicrobials, which makes them very hard to treat. And this can include bacteria as well as fungi like Candida auris. Here you can see a list of urgent threats from CDC's 2019 threats report with Candida auris, among some other multi-resistant multi-drug resistant bacteria that you've probably heard of, like carbapenem-resistant Acinetobacter or CRE, which is now carbapenem-resistant Enterobacterales. And these pathogens behave very similarly to Candida auris. So some of the strategies that I'll discuss later are effective to contain and prevent the spread of MDROs, including Candida auris. So hopefully you'll learn more than just about Candida auris today. So these MDROs are also similar because they all affect patients that are very sick. So those with multiple and prolonged healthcare stays, those with invasive devices like tracheostomies or central lines or PEG tubes or urinary catheters, those that are ventilator dependent, have recently received antibiotics or antifungal medications. And infections with MDROs have been found to be associated with worse outcomes. So they have longer hospital stays and higher mortality. But I do want to take some time to share what we know specifically about Candida auris. So Candida is made up of many species. Candida albicans used to cause most of the human infections, but over the years, other species have become more common and now make up more than half of all Candida infections. And Candida auris is different from other species of Candida. Most Candida live in the gut and people get infected from their own gut flora, but it's often not spread between patients. So isolation precautions are not required and outbreaks are rare. Antifungal resistance is different for different species and is generally low, but we've found that it's increasing among some specific species. But Candida auris acts differently from all of these other species, and so we're going to go into more detail to explain why. So these are the differences. These differences are what make us so concerned about Candida auris. It's highly drug resistant. Patients can become colonized and develop invasive infections. And it spreads in healthcare settings and can cause outbreaks. As far as resistance, Candida auris is much more resistant than all other species. There are really only 3 major classes of antifungal medications available to treat Candida infections, and 80 to 90% of isolates in the US are resistant to fluconazole. A quarter are resistant to amphotericin, and a smaller percentage, only 2%, are resistant to echinocandins. But the number of echinocandin cases or pan-resistant cases, which are resistant to all 3 of these drug classes, is increasing quickly, which is especially concerning because echinocandins are the first-line therapy and often the only therapy available to treat Candida auris infections. So these numbers are what we see nationally, but it's important to keep in mind that we do see some differences regionally based on which strain of Candida auris is circulating in the area. C. auris can cause many different types of infections, like bloodstream infections, urinary tract infections, and respiratory infections. But people can also be colonized, meaning they carry Candida auris, but have no signs or symptoms of an infection. And we shouldn't ignore colonization because colonized people can still develop infections later. And they can also still spread Candida auris to others. So they require the same infection control precautions as infected people. Candida auris primarily colonizes the skin, which is unique. You know, as we mentioned, most Candida are in the gut. And it's why we recommend screening both the axilla and groin with one swab. Oh, sorry, that picture doesn't look right. We recommend screening the axilla and groin with one swab, but Candida auris can also colonize other body sites like hands, toes, and the nose. Colonization can persist for a long time, often months to years, especially for patients who remain in healthcare facilities. So patients should remain in precautions for their entire healthcare stay. And unfortunately, there are no recommended decolonization strategies at this time. There have been outbreaks in facilities who use things like CHG bathing. So there's not a lot of evidence yet, but something to be aware that, you know, there's no magic bullet to rid people of Candida auris. The auris can cause invasive infections with high mortality. About 5 to 10% of colonized patients will develop bloodstream infections, which, as you know, are very serious infections with a very high mortality. And we've found 40% die within the first 30 days after they are identified as having Candida auris. Since Auris was first reported in the US in 2016, there has been a steady increase in cases, as you can see here. Both those detected through clinical specimens and those identified through colonization screening, which is in green. The clinical cases are in blue. And you can see the number of cases increased even more starting mid-July throughout the COVID pandemic. And these cases have occurred all over the country. And initially, most were in New York City, New Jersey, and Chicago, but other states have seen significant increases in the last few years, including California, Florida, Texas, Indiana, the Mid-Atlantic around Washington, D.C., and, you know, recently Nevada. And also, initially, most cases were related to travel abroad, but at this point, most cases are associated with local transmission, not necessarily travel, although that's still possible. And we found that the prevalence and transmission is disproportionately higher in higher acuity long-term care facilities like ventilator-capable skilled nursing facilities and long-term acute care hospitals, or LTACs, as compared to non-vent capable SNFs and short-term acute care hospitals. And this is likely the case for a few different reasons. You know, a combination of having higher acuity patients, much longer lengths of stay, and often fewer infection control resources. But that, I say that, but that doesn't mean that transmission does not happen at these other facility types like SNFs and acute care hospitals. In fact, we've seen an increase in acute care hospital outbreaks during the COVID-19 pandemic, including this one. So some of these acute care hospital outbreaks have occurred in COVID units. So this one occurred in a large Miami hospital where over half of the patients screened on the COVID unit were positive, and 17% went on to have positive clinical cultures. And this investigation found that the healthcare personnel were not following recommended infection control practices, including wearing multiple layers of gowns and gloves and using PPE for multiple patient encounters. You know, their practices really shifted on this unit because they just figured everyone had COVID and didn't think about the other things that they could be spreading. And there was also a lot of fear of COVID at the time. And so some of these additional non-recommended practices, they didn't necessarily consider the unanticipated consequences. So really briefly, I wanted to share what we've seen in Nevada so far, specifically Southern Nevada, where the majority of cases have been identified. And I know Kamisha shared this, but I did want to revisit it because as you can see, Nevada has had a very high proportion of clinical cases, higher than other states. And this is concerning to us because it often suggests that screening cases are not being detected. And we also found that acute care hospitals were seeing very high numbers of clinical cases. Most acute care hospitals nationally would see no more than 1 to 2 clinical cases per month, but some in Nevada were seeing, 5 to 8, even one saw 10 clinical cases in a month. But that's changing. You can see this epi curve shows the increase in cases over time and the substantial rise in screening cases over the last few months once colonization screening was started. So the proportion of clinical to screening cases has significantly changed as the detection of screening cases has improved. The increase of cases in Nevada happened more quickly than in other states. So this is just looking at clinical cases, but it took Nevada just over half of a year to identify 83 clinical cases, whereas it took other states 2 to 5 years to accumulate that many clinical cases. So this is really, we've seen a really dramatic increase, which I think was concerning and got everyone's attention. Nevada has also had multiple pediatric cases, as Kamisha mentioned. There have been less than 10 pediatric cases previously identified in the US ever, and there have not been any previous clusters of pediatric patients identified at a single facility. So far, Nevada has identified 5 pediatric cases. I know for most of these were identified on pediatric units in hospitals with adult CRS cases. 3 of these cases were identified from a single ICU, and all 3 of those cases were less than 1 year of age, and 2 of them had never left the hospital. And all 3 of these in this ICU had bloodstream infections, and 2 of them developed endocarditis. So this is, concerning for transmission from adult patients in a facility to pediatric patients through shared exposures like contaminated equipment or common care surfaces like procedure rooms. But don't worry, you can prevent spread of CRS and other MDROs. So we're going to spend some time going through some strategies for that. We have found that CRS spreads throughout entire units, not just to direct roommates. So this is a unit in a Chicago VSNF that started with 1 case, and months later it had spread across the entire unit. And these patients did not just have CRS. They had a variety of other MDRO combinations that you can see with a variety of colors. One thing that probably contributes to this is that CRS persists in the environment for a very long time and contaminates surfaces and medical equipment. So it can be found on high-touch surfaces like bed rails or overbed tables, but also shared medical equipment like vitals monitors, glucometers, Hoyer lifts, all of which we've found to be contaminated before. And these are items that are used on multiple patients and may contribute to CRS spreading to other patients. And as we get into ways to prevent the spread of CRS, it's important to highlight that all of the facilities in an area are connected and share patients. This is not just one facility's problem. So what each facility does or does not do can affect the whole region. So preventing the spread of CRS or other MDROs is everyone's responsibility and requires that facilities work together So we really want to discourage like pointing fingers or placing blame on facilities, since, it's really involves everyone working together. So how do we prevent the spread of C. auris and other MDROs? So here are 3 steps. 1, identify as many people as possible who are infected or colonized in a region. 2, have good baseline infection control practices and ensure adherence to these recommended practices even before the first case. And 3, communicate at transfer to other facilities and units which individuals are infected or colonized with MDROs. So now we'll go into a little more detail on each of these steps, starting with identification. Cases are often identified through clinical specimens, so it's important to understand your lab's ability to identify C. auris correctly, because some lab methods can misidentify C. auris as other species like C. hemolonii or Duobus hemolonii. Also, know the local rules for public health reporting and isolate submission, even if you use a contracted or corporate lab. And also consider enhanced surveillance methods like identifying species of all Candida or yeast from any specimen type, not just sterile specimens, because some labs will not identify Candida from, say, urine or the respiratory tract to the species level because these may not be treated. But doing so, this approach is how some areas have identified their first case months before the first blood specimen was identified, and identifying it early gives you a chance to act early and prevent spread. Cases can also be identified through colonization screening. So that's when a swab is used to identify if a patient is colonized with an MDRO, even if they don't have signs or symptoms of infection. So different body sites are used for different MDROs. As I mentioned, we use an axilla groin swab for Candida auris. Colonization screening can be done in a variety of ways. It can be done on admission or on discharge, like for facilities experiencing outbreaks or transmission, or through a point prevalence survey, which is when screening is performed for all patients on a unit or in a facility to get a snapshot of who's colonized. And again, for these, it's not just focusing on roommates, but as we found, other patients on a unit can be healthcare contacts. But the type of screening and the type of patients that are screened should be based on your local epidemiology, and the health department can help guide you on making these decisions. But it's important that you don't wait to respond. The sooner you screen in response to new cases or concerns about transmission, the quicker and more successfully you can intervene to prevent spread. We have found over and over that facilities that are more proactive and quicker to respond see fewer cases and less transmission. So one of the misconceptions that we often encounter is the concern that healthcare personnel can become colonized with Candida auris. But generally, healthy individuals without C. auris risk factors like, ventilators or indwelling devices, including healthcare personnel, are generally low risk for acquiring Candida auris. So this has been studied in facilities with outbreaks that have shown minimal risk of colonization to healthcare personnel. And there are a few examples, but one recent study of over 700 healthcare personnel providing care to patients with C. auris showed no colonization among the healthcare personnel. But remember that healthcare personnel can still transmit C. auris from patient to patient through contaminated hands, PPE, gloves. So adherence to infection control is still very important. All right, the second step after identifying cases is infection control. And again, one of the misconceptions that we often encounter is that hand hygiene with soap and water is superior at killing organisms on hands compared to alcohol-based hand sanitizer. But ABHS is better than hand washing at killing bacteria and Candida auris. ABHS is less damaging to the skin compared to soap and water, and is the preferred method for most clinical situations unless hands are visibly soiled. For acute care hospitals or facilities experiencing transmission, contact precautions should be used for patients with C. auris and other similar MDROs like carbapenemase producing organisms. Private rooms are preferred, but not required. And if private rooms are not available for everyone needing contact precautions, you can prioritize private rooms for individuals with uncontainable secretions or excretions. You can also consider cohorting individuals based on their colonization with certain selected high concern MDROs like C. auris or CPOs. And these patients should be restricted to their room except for medical necessary movement. So that's contact precautions. But enhanced barrier precautions is an alternative that can be used in nursing homes only. This approach is slightly different because it involves the use of gown and gloves only for high-touch activities for residents with known MDROs or those on the same unit who are at increased risk because they have indwelling devices or wounds. That's all I'm going to say about enhanced barrier precautions, but I realize there may be a lot of questions about that, and happy to, I'm sure the health department can help or others at CDC can provide even more details on this or guidance. So another misconception is that residents or patients that were that are colonized with Candida auris and are rescreened and test negative can have contact precautions removed. This is not true. Colonization can last a long time, and we frequently see that colonized individuals can test negative, then test positive again. So you can see on the bottom right, this is data from patients in Chicago that screened positive, then had one, even three, I think patient 8 had 3 negative swabs, and then tested positive again. So a negative rescreen is not a reliable indicator that the person no longer has C. auris. And for this reason, rescreening is not recommended and patients should remain on precautions for their entire healthcare stay. Because C. auris is shed into the healthcare environment and persists in the environment for so long, environmental cleaning and disinfection is extremely important. So at a minimum, high-touch surfaces should be cleaned and disinfected daily, but not just the patient's immediate care environment. It's important to clean and disinfect non-disposable shared equipment after each use. And make sure to ensure that this is done, make sure it's clear who's responsible for cleaning which surfaces or equipment to make sure nothing gets missed. And it's important to follow the manufacturer's instructions for disinfectants, paying special attention to contact time. But not all products work against C. auris, including some common healthcare disinfectants. So we recommend using disinfectants on EPA's List P because they have been specifically tested and approved by the EPA. But if those are not available, List K products are effective against C. diff should also work. And to improve compliance for all of these IPC elements, it's important to make sure supplies are readily available, that you're educating and training staff regularly, and conducting routine audits. So doing observations or doing fluorescent marking for cleaning audits. But don't wait to improve IPC practices until you have a case, especially since facilities are often not aware when their first case is admitted. So start now evaluating and strengthening your IPC, and also consider going ahead and using disinfectants, List P disinfectants effective against Candida auris, even if you don't have a case. Finally, communication. I don't think anyone would disagree with this statement. Communication definitely makes everything better, but has proven to be a huge challenge with Candida auris. We often hear of cases that are transferred and the receiving facility is unaware and didn't implement appropriate precautions and potentially spread to other patients. And this can happen between facilities or even between units in the same facility. So it's important to remember to communicate. Also, if someone was tested and maybe their lab result is pending, so that the receiving facility can keep them in precautions empirically and be on the lookout for those results. We've also seen that gap occur and lead to transmission. And because communication tends to be so challenging, really think about how this information is communicated, whether it's verbally or written, documentation, or both, and how it's communicated or documented. Is it, hidden in a medical record where no one may stumble upon it? And how can you ensure that the information that's communicated was received? And, a great rule of thumb is to give what you would want to receive. And communication is also important with the health department. So it's important to notify the health department when you find positive specimens so they can help determine if it's a new case. They can help you strategically plan next steps, give you updates about what's happening with C. auris locally, answer infection control questions, and facilitate getting that isolate sent to other labs for testing. So I'll just leave you with some next steps that I hope will help prevent the spread of C. auris in your facilities and in Nevada. It's important to identify gaps in infection control practices and work to improve them even before you have a case or transmission. Definitely be on the lookout for C. auris from clinical specimens, but also consider colonization screening to improve case detection based on the local epi. Assess and improve your communication practices around MDROs and share this information with others. And we also have resources available online. There's C. auris website has a lot of resources, and then others from CDC specifically around infection control. And the bottom one is actually from Virginia, but that's a webinar series that we worked with Virginia to do and does have continuing education credits, so that's a bonus. So I think that's it. Thank you, and I will stop there.
Thank you. Sorry. Thank you, Megan. Emily, you can go ahead and share your slides, or did you want me to share from my end?
I can share them so I can control them. Just one moment. Okay. Well, good morning, everybody. I'm really excited to talk with you all about proper specimen collection and shipment of those Candida auris screening swabs to our laboratory, the Washington State Public Health Laboratory. This is a really important aspect and has a lot of important details. And so it's really important that we go over all the various pieces that need to come together in order to properly collect and ship those swabs to us for testing. So really briefly, Kamisha mentioned at the beginning of this presentation that the Washington State Public Health Laboratory serves as the West Regional Laboratory for the Western region of the AR Laboratory Network. So as the regional laboratory for the West region, we not only do testing for carbapenemase producing organisms in Candida auris for our own state of Washington, but also for all those states you see on that are kind of that coral orange color. So that's Oregon, California, Nevada, Alaska, Hawaii, and Guam. Okay. So whenever testing is conducted through our laboratory, we provide these sample collection and shipment instructions that I've put some screenshots of those on this screen. These instructions really offer a detailed guide and should be followed really closely whenever you're collecting and shipping specimens to our laboratory. Today, I'm going to go through some of the basics and highlight some certain aspects of these instructions. My presentation today shouldn't totally replace you and your staff reading through this document and using it as a guide anytime you're collecting and shipping specimens. So I definitely recommend, potentially following along with these instructions so you can kind of mark some of those important pieces. And if you ever have any questions on the collection and shipment instructions, definitely reach out to our laboratory or your partners at the state. And they'll be happy to answer your questions because we really want to ensure that specimens are being collected and shipped properly. All right, so first focusing on specimen collection. So our laboratory can only test a specific type of swabs, and any other swabs that are received, we cannot test those. So we can only accept e-swabs with liquid amines. As I mentioned, any non-approved swabs cannot be tested and we'll have to coordinate recollection. So as previously mentioned, we can provide all of those supplies upon request. It's best to really rely on the supplies we provide so there isn't a, mix up and then we end up having to reject a ton of patient specimens. The next important piece, and Megan alluded to this a little bit, we only want one swab collected per patient. In those collection and shipment instructions, there are really detailed instructions provided on collecting from the left and right axilla groin with one swab. So those are a really great guide to make sure you're collecting those swabs properly, because we want to make sure we're getting the highest quality specimen possible. So once those swabs are collected, immediately place the swab in the tube that's provided in the collection kit. Then snap off the end of the swab at the indicated portion. There's an example shown on the right-hand side of this slide. There's a little indentation with a little red mark. It's really easy to see where that swab needs to be snapped off. So then leave the end with the swab tip in the tube and then discard that second snapped off piece. Any samples that arrive without the swabs in the tube cannot be tested at our laboratory. Finally, ensure that the cap is screwed on really tightly and sealed with the provided parafilm strip. We do this because we really want to make sure that those samples don't leak in transit, since we can't test leaking specimens. And for those of you who aren't familiar, parafilm, it's like a thin waxy strip that I like to describe as tape that isn't sticky. Because it's waxy, it sticks upon itself, and it's really great at sealing those tubes and preventing leaking in transit. We definitely want that parafilm used and not any alternatives like tape, because that can impact our ability to quickly process specimens. Okay, labeling. And labeling is one of the most important pieces of this. So all specimens must be properly labeled or we may not be able to test them, or testing may be delayed because we need to reach out and get information confirmed before we can proceed with receiving those samples. So each sample must be labeled with 2 unique patient identifiers that exactly match what is on the requisition form. The most common unique patient identifiers we see are patient name, both first and last, and date of birth. There are some other alternatives like medical record number, but I really want to highlight that these identifiers for each patient really need to be unique, and they need to exactly match what is on the requisition. Here's just like an example I like to give. So this would be a case of inappropriate labeling and not matching patient identifiers between sample and form. So on the requisition form, the sample is labeled as Patrick Smith, but on the specimen label, it's Pat Smith. So in that case, we would need to reach out and confirm what is the correct name for that patient. So I really just wanted to highlight the importance of making sure those exactly match, not closely match, or very clearly that, you know, it's a nickname or an abbreviation of a name. We really need that information to match exactly. And I just really wanted to highlight that, you know, oftentimes we can reach out and get the appropriate information confirmed and we can proceed with testing. But, you know, it is possible that if a specimen really has gross labeling and requisition form issues, that we may not be able to test that specimen. And we really want to avoid that as much as possible. Printed labels are, you know, really preferred for the tubes since they're quite small and can be hard to write on, but handwritten labels are acceptable. If you are going to use a handwritten label, please make sure that you're writing clearly and don't use a pen that'll smudge. I've seen, you know, it happen where somebody used like a gel type pen to label specimens, and then in transit, everything smeared, and we had to reject all those specimens because we simply could not read those labels. So I talked about the requisition form a little bit in that last slide, highlighting that there need to be 2 unique patient identifiers on the specimen itself that exactly match the requisition form. So this is a required piece of submission to our laboratory. All specimens that we receive must come with our Washington Public Health Lab requisition form. And I really want to highlight that it needs to come with this form specifically. Please do not send face sheets or any other paperwork for a patient. Face sheets contain a lot of sensitive patient information that we do not need in our laboratory. We don't want it. The only paperwork we want for each screening specimen is our requisition form. And I really want to highlight that samples cannot be processed at our laboratory until a requisition form is in hand. So if we have specimens that come in without the requisition form, then they're going to have to wait and sit in our laboratory until we have those on hand. So it can really delay test results if we get specimens that come without a form. So it's likely that you will be provided a pre-filled version of the form from Public Health, pre-filled with information like the address and fax number and the specific test requested. But a blank version of our form can be found on our website. I've included a link on this slide, which I know will be sent out after the presentation. That blank version is available, but having that pre-filled form from Public Health can definitely be preferable. So you're just worrying about filling out the patient information and other relevant information to that specific test. So similar to the specimen labels, typed forms are really recommended. Handwritten forms are acceptable, but again, really must be legible. So we really encourage folks to use those typed forms. Now I'm going to go over some really important pieces of the requisition form itself. So first, I want to focus on the patient information field. This is really one of the most important fields on this form. All the fields are important, but this one is really vital to processing of these samples. So you really need to make sure that this section is completed and that those patient identifiers on the specimen are exactly matching what you're putting on the requisition form. So this includes information like last name, first name, date of birth, gender. The next piece I wanted to focus on is the secure fax number. So currently we primarily rely on sending out results via fax. And so we need to make sure that we have the appropriate secure fax number on file and validated for each facility that is listed on the requisition form. So I've put some arrows to the various fields where confidential and secure fax numbers can be listed. It's really important that those are listed on the form every single time because our processing folks, they make sure to match up those fax numbers with what we have in our system. So we really ensure that we're not sending results to the incorrect fax numbers. We do have to validate secure fax numbers before we use them for the first time, and we will work with you on getting those numbers validated when you screen for the first time. Next, I wanted to focus on the test requested. So it's really important that the appropriate test is selected on these forms so our staff know exactly what needs to happen to these samples. So anytime you're doing Candida auris colonization screening, there's only one acceptable test, and that's under the test requested field under colonization screening, that second option, Candida auris colonization screening. Lastly, collection date is really important and really the most common field that we see left blank on the form. We have to test specimens within 9 days of collection, so it's really important to us that we have that information so when we receive those samples, we can ensure that specimens are still viable. This is by far the most common issue we see with the forms is everything will be filled out perfectly, but there's nothing in the date collected field. So really pay attention to that and make sure that you're completing that. Because if we get forms with, you know, incorrect collection dates and it's outside of the 9 days of collection, then samples may be rejected. So now that we've discussed like kind of the collection and labeling and paperwork side, I really wanted to talk about category B shipping, which is really an important piece of this entire process. So it's really important that each labeled specimen that is properly sealed is then placed in a biohazard bag, and those are provided with the collection kits. We should only have one specimen per biohazard bag, and that biohazard bag should be firmly sealed as well. After you've put that specimen in the biohazard bag, make sure to put the completed requisition form in the outer pocket of the biohazard bag. We often call it the kangaroo pouch. It's on the outer side of the biohazard bag. It's unsealed, it's just a pocket. So you put the requisition form in that kangaroo pouch and it won't be in direct contact with the specimen, but it will be paired with the specimen. So when they arrive at our laboratory, we can match those up really quickly. It's really important that you put the requisition form in that outer pocket. The requisition form should not be touching the specimen, and that can lead to additional processing times. So once those biohazard bags are sealed, then they need to be placed inside the 95 kPa bags, which are also provided with supplies you receive. Those kPa bags, they're a really thick plastic. They can hold multiple biohazard bags with specimens inside. And it's really important once those are filled that then those are sealed with the adhesive that is provided on those 95 kPa bags. And then lastly, once those sealed 95 kPa bags are all ready to go, then they'll be placed inside the category B shipper, which is the box that is provided with the supplies that you received. So category B shippers are really important and there are really specific requirements on these boxes. So proper category B shipping is absolutely required and really ensures the safety of all that come into contact with the package. That's everyone from, you know, staff at your facility to anyone at FedEx that comes into contact with them, all the way to the folks at our laboratory that receive and open packages. This is really important and really ensures that these packages are being handled in a safe manner. So category B shippers must meet certain guidelines and again are provided with the collection kits. These category B shippers, they will have this UN 3373 logo visible on the outside of the box. You can see an example of this logo on the bottom right hand of this slide. And this is really important that it's visible during shipping. Please, before you, complete packaging up this box, remove any labels that are obscuring that UN 3373, and don't place the FedEx label on top of it. It really needs to be visible again, so whoever's coming into contact with the package knows what is inside and that this is a Category B package. On the outside of the box, there's also an emergency contact label. Please make sure you complete that with, person responsible and the 24-hour number where to reach them. And then again, please really follow the sample collection and shipment instructions exactly. There's really detailed instructions on doing this Category B shipping correctly, and it's really important that you follow those. So I really quickly, really want to highlight that the importance of using appropriate Category B shippers. And, I mentioned there's some really specific requirements, and, it's really important to just use the boxes that we provide to you, because we want to make sure that these boxes are Category B compliant. You may be thinking, like, that UN 3373 label, that'll be enough. I can just put it on any box I have laying around, put the specimens inside, and we're good to go. And that's really not correct. That is a major issue, and something we would, definitely end up working with you on if that a box like this came to our laboratory. This is an example of a situation just like that. This was a box that we received filled with specimens. And this box was previously held Nestle diabetic vitamin shakes. And they just put that UN 3373 label on the outside of the box and put the 95 kPa bags inside with the swabs and sent them on their way. Please do not do this. I can't highlight this enough. It's really important that we're using proper Category B shippers. When in doubt, don't use it. It's best to rely on the shippers we provide, and we can always send additional shippers to you if you don't have any or you're not sure about a potential box that you might have. So next, it's really important that these Candida auris screening specimens are shipped cold. If they arrive to our laboratory without an ice pack, we cannot test them. Freezing samples is not a replacement for providing ice packs, so please don't do that. Another really important piece is only using chemical ice packs and making sure that you check for leaks before use. Please do not use water ice or ice packs, and please do not use dry ice. Just use chemical ice packs. There's a typo on that slide. Sorry for that. Ice packs should be placed between the 95 kPa bags and the Category B shipper. So this is taken directly from the collection and shipping instructions that I mentioned, and this is a really helpful guide to use along with the written instructions. It kind of goes through, what goes into where and all the important elements of Category B shipping. So please use this as a guide and all the written instructions as well. There are a lot of components of proper Category B shipping. They're all really important to follow. And so, really make sure that you're following this exactly. And then lastly, shipping your package. So we ship everything via FedEx, and we do provide the FedEx labels free of charge. Those will be included with your supplies and your Category B shipping materials. So once everything is packaged up properly, you have two options. You can arrange for a FedEx pickup by calling customer service. Numbers on the screen, but it's also really easy to find on Google. Or you can drop off packages at a FedEx location that accepts dangerous goods. And so not all FedEx locations will accept these Category B boxes. So make sure you go to the FedEx website. There's a link to the FedEx location finder on the FedEx website. And so when you're putting in your location, when you click on the More Filters button, you can go through various different types of FedEx locations, go down to dangerous goods shipping, select that, and the map will then show you any FedEx location that will accept dangerous goods. It's really important that you make sure that whatever FedEx location you plan to drop off the package at will be able to accept the package. So this is my last slide, just some final notes that are really important. So please make sure you stick to your scheduled collection date, and to the best of your ability. We understand, you know, that things happen and sometimes schedules need to change, but please make sure that you're communicating any schedule changes. At our laboratory, we work with a ton of different facilities and public health departments. And so we really like to make sure that our schedule is as organized and up to date as possible. There's no such thing as over communication when it comes to these. It's really important for all of us to be aware of any changes. Even though samples, you know, have up to 9 days from collection to when they're still viable for testing, please make sure that you're shipping specimens as soon as possible. You know, we want to make sure that we're not having to reject samples because they get to us after 9 days of collection. You know, there's sometimes FedEx delays, holidays, weekends. And so, you know, really make sure that you're shipping those specimens as quickly as possible and not, you know, waiting around to ship them, because that could potentially lead to an issue if there are any delays or a weekend or a holiday coming up. So after we receive the samples, you know, we really try and get results out as quickly as possible. Testing turnaround time is 2 to 3 business days. Our laboratory only conducts testing Monday through Friday. So keep that in mind if you're looking out for results over the weekend. And again, always coordinate testing with public health. Don't send any unapproved samples to our laboratory. And then again, when in doubt, please ask for help. You know, we understand that there are a lot of moving pieces when it comes to, you know, coordinating this, not only with public health, but within your facility. And there's so many pieces of completing the collection and shipping. It's really a lot. And so, you know, definitely reach out anytime you have questions. We're always happy to walk through any of the instructions with you. And that's all I have.
Wonderful. Thank you, Emily. Before we get into the question and answer portion, I just wanted to share my screen right quick. Can you guys see my screen? Should be a hand with the glove. Can you guys see?
Yes.
Okay. So we are working with our QIO, Comagin Health, to provide infection prevention training for our long-term care facilities. This is of no cost to you. It's online infection prevention and quality improvement education, coaching, consultation, and technical support for IPs, innovative methods to help you teach frontline healthcare personnel, and timely resources to help you address gaps and build sustainable infection prevention practices. There is a training tomorrow on the 29th utilizing ECHO. And we do have separate sessions separating Northern Nevada into Southern Nevada, so you all can work in groups and assist each other in your region. There is a QR code here where you can scan it with your cell phone, or you can text NBIPC to 59309 and access training information. I believe they send out training information to your phone on a weekly basis. And if you have any questions, you can email Infection Prevention Advisor at comagin.org. So I'll leave this up here for you to be able to copy this down. If you're on the phone, once again, that email address is Infection Prevention Advisor at Comagin, that's COMAGINE.org, O-R-G. So now we'll open it up for Q&A. We do have some questions in the chat, so I will read through those and the answers quickly. We do have an evaluation. There's one nursing CU available for this training. The link for the evaluation is in the chat. I'll repost it just in case you weren't in earlier. Where's the first question? So from Sarah Lopez, when we get a positive blood culture on admit, do we need to swab the entire unit of that patient? The second question was, can we place 2 Candida Auris patients together or cohort? So yes, you can place them together in cohort. You do want to make sure, if the patients have other organisms that they're infected with, that those line up as well. Because if somebody has CRE and the other person doesn't, we don't want to expose that patient to CRE. And then if they're admitted with positive blood culture, if they're, and CDC, correct me if I'm wrong, if they're placed on contact precautions, then no, you wouldn't have to screen. The screening occurs when they are positive, but we're not on contact precautions, and then we would screen that unit. Heather, somebody from CDC, if that's incorrect, please correct me. Brett asks, what are the best practices in handling CRS transfers between hospital and nursing facilities? And CDC's reply, from an IPC perspective, it would include clear communication between the hospital and nursing facilities about the positive case or cases, ensuring the appropriate precautions are in place, as well as the accepting facility understanding the other infection prevention and control recommendations with environmental cleaning and disinfection with List P or List K products. The next question was, if the specimens come from different sources with Candida auris, can they still be cohorted or colonized patients only? Answer to that.
Yeah, I can jump in. So yeah, when we find it in a clinical specimen, we assume that that's probably not the only place that they have C. auris on their body. So you don't need to differentiate whether it was found in the urine or respiratory tract or blood. We do treat all of those patients as colonized. So you don't need to separate based on body site or colonized versus infected.
The next question is, it best practices for a nursing facility to reject a CRS admission if they cannot properly care for CRS based on staffing, cohorting, or adequate PPE?
I'm not sure if Heather or someone else
Yes.
oh,
Hey, Megan, it's
Hey.
Heather. I did reply to Brett's question, and I really appreciate your question, Brett. So the answer that I provided is that based on the current recommendations, if you are a facility that currently cares for any type of resident that requires transmission-based precautions, you should be able to safely care for a patient or resident with Candida auris, whether that's an infection or a colonization.
That was a great answer. And yeah, I guess just to emphasize that, these type of pathogens are unfortunately becoming more common. And they're also common in this population. So, this is something that I think everyone should be comfortable with, and also, find out what resources they need to be able to take care of these patients. But it's no different than, caring for someone with C. diff or, one of the CPOs.
Ready, our next
This
question.
is Brett. Can I comment on that?
Sure, go ahead, Brett.
Sorry to jump in. I guess the question that I get that, and this is Brett Salmon, Nevada Healthcare Association. I'm the president of the association, and I guess the question that I have is more related to, I get that many facilities should have the capability to have dealt with these various issues in the past, and they should be able to deal with it currently. The question I'm asking is more on, because of the staffing struggles that we're having, and the increased pressure that CRS is going to put on dealing with your staffing in your facility, is it correct for a facility to say, I don't have adequate staffing at this time to handle additional CRS patients, and therefore I can't take them? There's a struggle right now between hospitals and nursing facilities, no different than when we were dealing with COVID. And I want to make sure that facilities hear the correct guidance on that, that if they can safely take, they should, but if they can't safely take, they shouldn't. Is that correct?
So thank you, Brett, for clarifying. I think it's one of those situations that it's a new bug that many in your region have not dealt with in the past, but I also feel like from the perspective as a nurse practitioner that worked in long-term care, yes, we have staffing struggles, and it does place burden whenever you have a new resident or patient that would require either contact precautions or droplet precautions or enhanced barrier precautions. But just because they have a positive Auris, that shouldn't limit the ability for that facility to be able to safely accept that patient or resident. It shouldn't be any different from accepting any resident with an MDRO from an acute care hospital. And it's going to take some time for the education to be provided to share that the same practices that we have in place for other MDROs is the same practices as with Candida auris. The only real difference between IPC so far is that there are a smaller number of disinfection products that have the EPA label of being, effective against C. auris, but there's list P and there's list K, and a majority of the facilities that we spoke with, when they have those two lists options, they've not had a lot of difficulty obtaining those.
And maybe just to add to that, I think your question is maybe not even so much just specific about C. auris, but about, the growing burden of C. auris and other MDROs in the region, and just how can facilities have more patients on precautions. So at least for nursing homes, I know that was a lot of the rationale behind enhanced barrier precautions and how to be more streamlined and be able to provide care without requiring so many resources in that setting. So I don't know if that's helpful, or if Heather has anything to add about enhanced barrier precautions to try and make that balance more feasible.
Alrighty, our next question is, can we scan swab all admissions coming from acute care hospital?
So I guess
And
that
Arlene, I
question.
think that will be based on your, oh, go ahead.
Oh, no,
You said, what was the
sorry,
question?
Keisha. No, this is Megan. I was just going to respond, but I'm happy to
Oh, you
let
can
you
go ahead.
respond. I mean, I'm assuming this is from someone in a long-term care facility. So, swabbing all admissions is, one strategy that could be appropriate depending on the situation. All of this is really, a balance of resources, and there are limited testing resources. So, I think it would be something that you would need to talk to the health department about, whether you need to screen all admissions, or if there's targeted population you want to work with, or for facilities that already have a lot of cases, whether the chance of getting a new case is really more likely than seeing spread in their own facility. So it really can be facility dependent and based on your situation and your patient sharing network. So I don't know that there's an overall answer to that, except to say that maybe talk to the health department to see what makes sense and whether it's everybody or it really needs to be targeted.
All right, the next question is, how long should a patient with confirmed CRs be on isolation? And the CDC recommendation are for the patient or residents remaining on isolation throughout their stay in your facility. The next question is the screening mandate requirement? Is it a mandate or a requirement? So when that is our recommendation, based on guidance we received from CDC for the screening, as Megan stated, it's based on capability, and then we're using ARLM for screening supplies. And so also their capability as well. But for just that there's so much spread in the South. Also, I know some facilities are looking at, which facilities are they receiving patients from that are popping positive or have known cases. So they're targeting, based on those facilities if they receive patients from, certain locations. But we did have a patient that was transferred from the South to one of our Northern Nevada hospitals that ended up being positive. So just because of the amount of spread we're seeing, and then also as how many, the transportation of patients moving between facilities within the South and also from South to North, we're recommending that you screen those patients and put them on isolation before you move them into like a general population setting. Next question is, what guidance are you providing colonized patients? Suzanne, is that more of what the information that's being provided to the patients, or what the facility should do when they are identifying colonized patients? That's from Suzanne James.
Can you hear me? Can you hear me?
Yes.
Okay. Yeah.
Yes.
My question is, it's to the patient, like the patient and the family, because a lot of these people, especially what's going on in Southern Nevada, they're being identified through a screening process due to exposure. So what are you telling them once you tell them that they're positive for this resistant organism? I mean, because for acute facilities, they're going to go home. So I'm sure they have a lot of questions.
So the information that we provide to facilities is based on guidance from CDC. So we can provide those links that kind of go through the education for the patient as well as their family member if they go home, and then also what colonization means, hand hygiene and different practices that they should have in place, especially if they're going home and being cared for a family member. And then as Megan mentioned, that the risk is low for those who are healthy individuals. So that's what, based on a facility to facility need on what they're requesting from our department, that's the information that we provide to them and share with their patients.
So I guess on a second addendum to that question is, what if their household contacts are not healthy individuals?
We have not received that question, but anything that we're not able to find on CDC's website, we are in constant communication with them to get questions for those kind of quirky situations that don't have a clear identified answer to them. So if we ran into anything like that, we would seek CDC's guidance and be able to develop a response based on the information they provide us. Question from Tori Pines, will facilities be provided screening swabs? How can we obtain? As Emily mentioned in her presentation, you would contact us for screening supplies, and we would put you in contact with Emily, and she would set up how many supplies, we need to know how many supplies that you need, when they would get that information, those items shipped to you, how to ship them back, all of that coordination occurs between us, Emily, and the facility requesting supplies. And Susan, I believe CC put a link in the chat for what is the CDC information for patients.
Thank you.
From the next question, if we have to swab an entire unit because we identified one case, must the entire unit be on isolation until all of those swabs come back? Heather or Megan, can you answer that one?
Sure. Yeah, that's not something, I mean, obviously, if a patient comes in and you are concerned about that individual, then we do recommend empiric precautions for a patient of concern. But if you're swabbing an entire unit, that is usually not feasible to put everyone on precautions, and they've had exposure, so that's generally not something we do, no. But it would be good to, get that swabbing done quickly so you can find out who's positive and prevent any further transmission.
Can you hear me?
All right. Yes.
Okay, so can I just piggyback on that? The reason why I'm asking this question is because of the ripple effect. We had a case, a positive case that was identified. We were then told that was identified on admission, or sorry, it was not identified on admission. The patient was here for a period of time. We had to swab every single patient that was on that unit for the entire duration of time that that patient was not isolated. That was a line listing of 90 patients, the vast majority of which had already been discharged. So that resulted in screening 15 patients, which were not isolated because we would be isolating a lot of people. And then of those 15, 3 came back positive. So then we were told we had to then test everybody on that unit. So do you see where I'm going with this? It seems to be we're like in a hamster wheel almost, kind of looking for a better solution.
So is the question about testing or about whether patients need to be on
Well,
precaution?
I think so. So like I said, there was a period, so a patient came in and a urine was done and it was a contaminated specimen. There was really no true clinical indication for that urine to be repeated at that time. The patient was then on the unit for a long period of time, decompensated and was upgraded, and another urine was done, which came back positive for Candida auris. So we were instructed to make a line listing of every single patient that was on the same unit as that patient for the entire duration of time that that patient went unisolated, which was almost a month. So as you can imagine, that was extraordinarily time consuming because we had a line listing of 90 patients. Of those, only 15 were still in house. So we had to swab those 15. Of those 15, 3 came back positive for colonization, 12 were negative. We were then told to re-swab the negative and then swab everybody who was on the same unit as the 3 positives, which created another extensive line listing. Do you see where I'm going with this? It's this tsunami of a ripple effect. And I'm looking for something that's a little bit more, that we can handle really, because, you've got your regular job on top of all of this, and this is entirely a manual process at this point.
Yeah. So, I see where I think the question is, that's one reason why we do some of these point prevalence surveys, because, it can be tough to track everyone down. And at a certain point, it's just better to assess the entire unit instead of, like you said, looking at people who overlapped and then expanding on from there. Because we know if you do find positives, those people could have, spread it to other people in the interim that it took to do the screening. So that is one reason why oftentimes, for a case, it really depends on the situation, but it can be easier to just screen everyone in a unit of concern up front, and not necessarily look, tease out who overlapped with who when. So I'm not sure if that kind of answers your question, but better to get a snapshot of everyone at once.
Alrighty, it's 11:34. We're supposed to end at 11:30. We did receive one question about a list of facilities where patients have been identified, and that's something I have to check with our state epi and our attorney general to see if that's something that we can do. And if so, then we will release, excuse me, I'll have to check with them to see on if that's something that we can do. And then if possible, then we'll release a list similar to what we have for like COVID facilities with COVID on the dashboard that we have. If you have any additional questions for our HAI team or for CDC, those can be sent to dpbhai@health.nv.gov. That's dbphai@health.nv.gov. Also, Emily and Megan, will we be able to share your slides to those who participated?
Yeah, the slides I sent you last
I don't
week,
know if you have to get
Kamisha, will
clear.
be good to go.
Okay. So we'll get those out as soon as we can. If you did not use the link on the flyer to register, we do need you to email us because we do not have your contact information to send you the slides. So those also can be sent to the dpbhai@health.nv.gov email address. Also make sure you complete the evaluation if you would like to receive CEUs and also to provide us feedback on this training and how to make future trainings better. Thank you for your time. You all have a great day.